All right, is this easily viewable for everyone?
Yep.
Okay. All right. So I think I'm Hannah. I'm one of the CA3s here, so I'm in my last year of residency. And the case I picked today is a case I had about a month and a half ago on my pediatric senior rotation. I thought it was just a nice illustration of one of the commonly tested pediatric illnesses, at least commonly tested for us, but not something that we actually end up seeing super frequently. So this is a case of infantile projectile vomiting. Our patient is a 6-week-old male, and he is presenting with non-bilious, non-bloody projectile vomiting for the last day. The vomiting has occurred after every single feeding for the past 24 hours and has been very clearly undigested milk. He's been exclusively breastfed since birth, and his feeds have occurred every 2 hours. So he's vomited roughly 12 times in the last day. Along with this, he has no history of fevers, and he has been making a normal amount of wet diapers per his parents, but has not had a bowel movement in the last 36 hours. They were concerned yesterday when he started vomiting, and after not being able to keep down several feeds, they took him to a different hospital where they diagnosed him with gastroenteritis and discharged him home. Since then, he has continued to projectile vomit after every feed, and so today they brought him back to the emergency department for reevaluation. His other past medical history, he was born full term, there was an uncomplicated pregnancy, and he was born by uncomplicated spontaneous vaginal delivery. He is the firstborn child of this couple and has been otherwise healthy and has not had to take any medications. In terms of his physical exam, this is his physical exam that was documented in the emergency department. Blood pressure, heart rate, oxygen saturation, all are within normal limits for his age. His temperature is 37.3 degrees Celsius, and his weight is also within the normal range for his age group at 5.03 kilograms. In terms of overall, he appears non-toxic. He's not in any acute distress. He's actually sleeping in mom's arms. His head and neck exam is notable for a flat anterior fontanelle, but he does have moist mucous membranes. The remainder of his physical exam is generally unremarkable with the exception of the abdominal exam. His abdomen is noted to be flat and without distension, though he does have a palpable epigastric mass kind of in the center of the epigastric region. This is a picture, this is not a picture from our patient, but it is a picture of what this may look like in more advanced cases that have taken longer to diagnose. It's kind of an olive-shaped mass here, and generally speaking, it is not tender to palpation, and our patient's is also not tender to palpation. Another thing to note is his skin is warm and dry, and he has intact capillary refill. Laboratory studies were sent, and his complete blood count was all within normal limits. Liver function tests as well were all normal, as was his basic metabolic panel. However, I would like to point out specifically that his sodium was 137, which is well within the normal range, potassium 5.1, which is also within the normal range for his age, chloride at 104, and bicarb at 22 are all within the normal range, and his glucose is normal at 98. Imaging was done in the emergency department of the abdomen, and this was notable for hypertrophic muscularis propria and elongated pyloric canal length with impaired gastric emptying, and this was highly suggestive of hypertrophic pyloric stenosis. This top image here is an actual image from our patient. This is the pylorus here. And this bottom right image is what a normal pylorus should look like. It's much smaller, much thinner on ultrasound. Here you can see very, very well the thickened muscularis propria. on both sides. You can see it's much longer, and you can see the canal here is a little bit narrowed. You can also see proximally that the stomach is full of fluid, so significantly delayed gastric emptying. So this is pyloric stenosis, and I think this is a pretty classic presentation of this pathology. Pyloric stenosis occurs due to the hypertrophy of the smooth muscle of the pylorus. This results in significant narrowing of the outlet lumen and can delay or completely prevent emptying of the gastric contents into the duodenum. Typically, patients present in the first 2 to 6 weeks of life with projectile, non-bloody, and non-bilious vomiting after feeds. Their physical exam can be notable for that olive-shaped mass in the epigastric region. This has actually become less common to find on exam as these are being diagnosed earlier with the widespread use of ultrasound. But sometimes you will still find the olive-shaped mass, and for our patient, he actually did have this physical exam finding. You may also see visible peristalsis after feeding. This usually occurs kind of in the window of immediately after feeding, but before the episode of projectile vomiting. And it's a result of the stomach trying to contract against that very stenosed, narrow gastric outlet. The etiology of pyloric stenosis still isn't clear. There's not one particular thing that definitively leads to its development. It seems to be a combination of both genetic and environmental factors. And the prevalence seems to vary in the US based a little bit on ethnicity, with Caucasian and Hispanic children being more likely to develop it than other ethnicities. But on the whole, the prevalence is roughly 1 to 3.5 cases per 1,000 live births. Risk factors, it's far more common in males than females. Depending on where you look, it's roughly a 4 or 5 to 1 male to female ratio. Being firstborn also puts you at higher risk, and the risk of pyloric stenosis development decreases with increasing birth order. So the later your birth order is, the lower the risk you have for developing pyloric stenosis. Other things, maternal smoking during pregnancy, preterm delivery, cesarean delivery, and a small for gestational age infant all increase the risk of development of pyloric stenosis. There's also some evidence for genetic component, as there's higher concordance of pyloric stenosis in identical twins when compared with fraternal twins. Fortunately, there is a definitive surgical treatment that's relatively easy to perform, and that is surgical pyloromyotomy. I think the big question for us as anesthesiologists is pyloric stenosis a surgical emergency? I can say that the answer to that is no, it is not a surgical emergency, but it does require urgent medical management, as it can cause significant derangements in electrolytes and in acid-base status. So the metabolic derangements that occur in pyloric stenosis are primarily due to the projectile vomiting. This vomiting leads to loss of acid or protons, as well as potassium and chloride from the gastrointestinal tract. This commonly leads to a hypochloremic, hypokalemic metabolic alkalosis. The body in the beginning usually does a reasonable job of compensating for this, as the kidney appropriately alkalinizes the urine with bicarbonate wasting. However, the longer that the vomiting goes on, the more dehydration occurs and the more water loss occurs. And this can lead to activation of the renin-angiotensin-aldosterone system. Aldosterone subsequently leads to retention of both sodium and water to preserve the blood volume. This has downstream effects on sodium-potassium exchange and distal sodium reabsorption in the nephron, and can actually further lead to increased potassium and acid or proton losses. And this paradoxically acidifies the urine and worsens both the hypokalemia and the alkalemia. So the longer that this goes on, the worse that it gets due to the body's attempt to preserve blood volume. So specific anesthesia considerations for these cases. The dehydration should be corrected to euvolemia prior to surgery. This helps both with some of the metabolic and acid-base derangements, and it also helps prevent wide hemodynamic shifts on induction of anesthesia. Maintenance fluids should be maintained with a glucose source, as infants under the age of 6 months have an immature liver and impaired gluconeogenesis. You can also add potassium supplementation to these fluids that can be helpful in correcting the hypokalemia. Serum metabolic alkalosis is very important for us in anesthesia, as the alkalosis is translated to the cerebrospinal fluid. You also get, in addition to the serum alkalosis, you get a cerebrospinal fluid alkalosis. As we know, the brainstem is very sensitive to changes in the pH of the cerebrospinal fluid and will either increase or decrease the respiratory drive based on changes in the pH. Alkalinization, in particular, of the cerebrospinal fluid leads to respiratory depression and can actually lead to complete apnea. The depression in the respiratory drive is significantly worsened by the general anesthetics that we administer and by opiates for pain control afterward. And this is why it's very important to make sure that the acid-base status is corrected prior to proceeding to surgery for these patients. I think it's important to note that it actually can take several hours for the CSF to equilibrate after the correction of serum pH. So your serum pH may look normal, but it may take additional multiple hours to actually correct the pH of the CSF. And so these patients are often still at increased risk of respiratory depression afterward. And I think another big one for us is these patients have an increased risk of aspiration on induction due to the delayed gastric emptying. Because of this, it's recommended to place an orogastric tube and suction the stomach in multiple positions, somewhere between 3 and 4 positions, depending on the resource that you look at. So supine, and then left lateral decubitus, and then right lateral decubitus positions, and some resources also recommend suctioning the stomach in the prone position. So how do we manage the airways of these patients? Historically, these patients were awake intubated to avoid the risks of aspiration and hypoxemia. However, data from kind of the late 90s changed this practice when there's some data that showed there was improved first pass intubation success and shorter time to intubation in patients receiving general anesthesia. And there was no increase in complication rates. Therefore, awake intubation is no longer recommended for these patients. In general, classic rapid sequence induction with pre-oxygenation, cricoid pressure, and no bag masking like we do in adults is not recommended. And this is because the physiology of infants is different. The infant airway is far more compressible than the mature adult airway and can be easily deformed by external pressure. And this can make intubation not only more challenging, it can actually make it impossible. Their functional residual capacity is also decreased due to increased chest wall elasticity. And they have comparatively large abdomens. They also have increased oxygen consumption when compared to adults. So this can lead to much more rapid desaturation. So oftentimes we're not able to do rapid sequence induction and intubation, as these patients are at much higher risk of desaturation. They often require gentle bag masking prior to intubation after induction of anesthesia. In terms of maintenance of anesthesia, or rather induction of anesthesia, there is not any data to suggest that intravenous versus inhalational induction of anesthesia is superior. They are both used, and they are both used pretty safely. However, with both of these, paralytic is commonly used to optimize the intubating conditions, as well as for surgical relaxation. With either technique, I think the most important thing is ensuring an adequate depth of anesthesia or paralysis prior to intubation, as this can reduce the risk of regurgitation and aspiration. Maintenance of anesthesia is generally accomplished with inhalational anesthetics, though it is recommended to avoid nitrous to prevent bowel gas expansion. Pain control for these patients is typically achieved with Tylenol, intravenous, rectal, or postoperatively by mouth. And local infiltration by surgeons is also pretty common. You could do regional techniques for these, such as rectus sheath blocks or transversus abdominis plane blocks to supplement the analgesia, but there's actually no data to suggest that these are superior to just infiltration of local by the surgeons intraoperatively. And then in general, we avoid opiates due to the increased risk of respiratory depression from CSF alkalosis. So back to our patient. The ultrasound he had in the emergency department was consistent with pyloric stenosis. Fortunately, he was diagnosed pretty early and his labs were without significant metabolic derangements. He was still admitted to the general surgery service overnight and was started on maintenance fluids of normal saline with 5% dextrose and 20 milliequivalents of potassium chloride at a rate of 32 milliliters per hour. The following day, he was taken to the operating room for a laparoscopic pyloromyotomy, and on his pre-anesthetic exam, he was noted to have full fontanelles and wet mucous membrane, so he was well resuscitated. He also had a 22-gauge peripheral IV in place from the floor. Prior to induction, we placed an orogastric tube and we suctioned him in the supine, left lateral, and right lateral decubitus positions, and we had significant return of gastric contents. We suctioned the stomach in each of these positions until we were no longer able to achieve return of gastric contents. Afterward, he was very upset with us and crying, taking many deep breaths. So we were able to pre-oxygenate him relatively well. And we actually did a modified rapid sequence induction for him, fentanyl followed by propofol and rocuronium. And we did not end up having to bag mask him after induction. He tolerated it very well. After he was apneic, we used a Miller 1 blade, and the trachea was easily intubated with a 3/0 cuff endotracheal tube. Of note, there were no gastric contents in the oropharynx at all during intubation. So I think the suctioning of the stomach helped us significantly in this case. We continued his dextrose-containing fluid from the floor at the same rate, and he was maintained on sevoflurane for the duration of the procedure. For pain control, we gave him IV Tylenol, and the surgeons infiltrated local at the surgical site. At the end of the procedure, he was reversed with Sugamidex, and we suctioned his OG tube one more time prior to removal. He was extubated fully awake, and that extubation was uneventful. He remained nothing by mouth for the next 2 hours after the procedure, and then subsequently resumed feeding without any complication. His pain was well controlled throughout his stay with Tylenol alone, and he was discharged home the following day, and he has had no further complications.
Dạ thưa Long ơi, thầy chưa mở mic ạ.
Sorry. Can you hear me?
Yes.
Okay. Thank you for your great presentation, because I think the topic is so interesting. Also, even though from my resident, I don't think they have seen some case like this from our department. But I hope that they can send you some the good question that relate to about how can you handle the patient by using the fluid by the using the drug. Now I hope there's some question from my resident. Because with them, I think it's the very news. I don't think I have seen some case like that. But one of the most important thing we want to know is the so you always set up the stomach tube in the patient first.
Yes, so we placed the orogastric tube while the patient was awake prior to induction. I think at some facilities, they may still place a nasogastric tube on the floor once the patient is admitted. For us, we did not have that. They did not come from the floor with a nasogastric tube. If they have a tube already in place, that can be suctioned, but I think the main caution is that if you don't get anything back from the stomach, it could just be that nasogastric tube has become blocked or is malpositioned. So in that case, it's prudent to place an orogastric tube and make sure that you do have return of gastric contents and kind of empty the stomach out as best you can before induction of anesthesia, just to reduce that risk of aspiration.
Okay, because we have some different situation, because you know that in this patient always in the dehydration situation. So if you cannot set up the IV, what should you do?
I'm sorry, my computer lagged for a sec. Can you repeat the last part of that?
I mean, yeah. I repeat, because in some case we cannot set up the IV infusion. So what will you do in this term?
You mean you don't have the ability to have an IV for the anesthetic?
Yes.
I think for these
because
patients,
you know that. Okay. Sorry.
Sorry, no, go ahead. I apologize for interrupting.
Yeah. Because in this patient, you know that the patient always in the dehydration position situation, so it's difficult to set up the IV, the IV line.
So I think
So in some cases,
I think it can be useful to use ultrasound. These patients really should be volume resuscitated before they're coming to the operating room. And it's really challenging to do that orally since they don't have a functional gastric outlet, essentially. And so I think, in these cases, if you were unable to obtain an IV, ultrasound, using ultrasound to obtain the IVs is typically what we would do if we had difficulty. I think, I would say, I'm not sure if Dr. Stroud or Dr. Olako feels differently, but I would say for these patients coming to the operating room, I think it's so imperative for them to be fully volume resuscitated that if you were unable to obtain an IV, you probably could consider an IO for a short period of time to an intraosseous line to volume resuscitate them. And then once they're volume resuscitated, then place an IV once it was a little bit easier to do so. I don't know if there's data to support that, but what was that?
Access. I don't think IO is an access. I don't think they have that.
Okay.
Hi, Dr. Sarah, but we get now we had the OR. Now we had the OR.
You do have it now.
Yes.
Okay. Yeah.
Because we have some cases like that, and then we cannot set up the IV line, and now we have the OIs, and we can set up the osseous line, and then we can infuse a little bit, the fluid, and we just make sure that the patient is aware about the dehydration, and now it's easy to us to find the IV.
IV, yeah. I wouldn't take them back to the OR until they're fluid resuscitated. I agree with Hannah. It's not. You're gonna have more problems if you do it the other way.
I think from our resident, they don't have they have seen some case like this. But if you say something about the intercession, I think it's very useful, because I think the situation is the same about the pylori stenosis and intercession.
I think I see one question in the chat about calculating the amount of fluid and glucose intraoperatively. It's a really good question. There is actually a formula, I don't recall off the top of my head, I would have to look it up, to calculate how much glucose a child requires. I don't want to tell you incorrectly, but there is a formula, and I can find it for the Q&A on Friday. And so you can calculate essentially how much glucose they need and then use that as your guide for maintenance fluids. Oftentimes what we actually do in practice is we will continue whatever they're on from the floor, as the maintenance fluids have already been started. But the other kind of old rule of thumb that we often use is the 4-to-1 rule, where it's roughly 4 milliliters per kilogram for the first 10 kilograms, and then 2 for the next 10, and then 1 milliliter per kilogram for every additional kilogram on top, 10 kilograms on top of that. So for this patient, I believe he was on 32 milliliters per hour, and he was 5 kilograms. So I think that's a little over what it would be from the 4-to-1 rule, but that's kind of the rough rule of thumb that we actually use in practice.
I think the question from my resident is how can you combine between the fluid and the glucose together, the ratio?
Yeah, so we use just a glucose containing fluid as our maintenance fluid. So something like dextrose half normal saline or dextrose normal saline with a potassium additive is usually what we use. So it is pre-combined into like a solution that is both half normal saline and 5 dextrose, or normal saline plus dextrose.
Dr. Vinh, can you hear it well?
Yeah, thank you, Dr. Hannah.
So we can move to the second question.
Oh, sorry, let me go back to the chat. Sorry, I didn't see that there were more. The perfusion strategy. I want to clarify and make sure I understand the question so I can answer it appropriately. Is the question asking like
I think
vasopressors?
the question is just like the first question. Yeah.
Oh, like the first question. Okay. So for these patients,
so you can move to the third question.
Yes. In terms of, do we use any drugs before placement of the orogastric tube? No, we did not. Oftentimes orogastric tube placement in these infants is actually pretty easy. It's going to make them really angry. They're going to cry and be very upset with you. But usually it's not a challenging placement. And so in order to minimize any sort of risk of respiratory depression, we did not give any medications prior. And aside from the crying, the patient actually tolerated it reasonably well. Good question about ultrasound to assess gastric volume before induction. You certainly can. We did not use gastric ultrasound to assess prior to induction. We simply placed the orogastric tube and suctioned in the 3 positions until we were not able to get any more gastric contents. And I will say that we actually removed the orogastric tube and replaced it in between each positional change to kind of ensure that we were getting everything that we could, and that the orogastric tube wasn't just staying in one spot and the gastric contents were moving around it. But you definitely can use gastric ultrasound. There are some guidelines for that. I think there was a paper that I saw that had some guidelines. I think if the stomach is not full, I think it's still prudent to place the orogastric tube before, for a couple of reasons. You may still get some stuff back, even if the stomach doesn't look super distended on an ultrasound. There may still be some stuff in there, and oftentimes you'll still get something, and so I think just to diminish the risk, I personally would still place the orogastric tube, even if the stomach looked okay on ultrasound. Next question. So if you do run into emesis or vomiting during intubation, what is the next step? So I think I would treat this as I treat any sort of gastric contents in the posterior oropharynx in any patient. When we intubated this patient, we did have our suction, our Yankauer suction readily available. And so I think if I put the laryngoscope in the mouth and I saw gastric contents, I would suction the gastric contents and I would try to secure the airway as quickly as possible to prevent the gastric contents from going into the airway, or prevent further gastric contents from entering the airway.
From the last question, I think that I can interpret like this. In some case, when you intubate and then you realize that maybe the patient already got the aspiration. What should we do? Yeah, I think the question meaning that.
Good question. I think it depends on how the patient does. If there are, so you can use an inline suction, endotracheal suction, to see after the patient is intubated, to see if there's any return of gastric contents from the endotracheal tube or from the trachea. And you can suction out as much as you can. If the patient does well during the case and doesn't require much oxygen support, and has no issues with ventilation, then I think at the end of the case, it's probably reasonable to extubate. However, if it's been a significant aspiration, you suctioned out all you can from the endotracheal tube, but you're still having oxygenation and ventilation issues, and I think at that point you would consider leaving the patient intubated and taking them to the PICU or the ICU, whatever you have available to you.
Yes, because normally we do not intubate. We decide to send to the ICU. Yes, and we will have mechanical ventilation with PEEP, and we use the antibiotic for this case.
Yeah. If it's a significant aspiration, certainly, especially if there are oxygenation or ventilation issues. We'll say that sometimes if the aspiration is very small and the patient does very well, and we don't have issues with oxygenation or ventilation, and we don't get much from suctioning the tube, then sometimes we will try and extubate the patient at the end. But typically, yes, if it's a large aspiration, we would also send them to the ICU. They would get antibiotics. They would remain intubated and ventilated mechanically.
So you will combine the antibiotic and steroid in this case?
For the aspiration?
Yes.
Generally, we don't start them in the operating room. Generally, they would be started by the ICU team. I think they are frequently started, but it is on a case-by-case basis. I don't think antibiotics improve aspiration pneumonitis per se, but aspiration pneumonia certainly. There's a use for antibiotics. So we generally don't start them, but they often do end up getting antibiotics in the ICU.
Sorry, because in the Vietnam, all the anesthesiologists have to take care of the work in the ICU. So this is a common question from our resident. Um, the other question, because you tell us that you recommend that you don't use any kind of the um, opioid in this patient. So I think that is the great idea, but in our situation, I think it look like so impossible.
Mm.
So
I
so
think
if you don't use the opioids, so you just use about the local anesthetic drugs, or also combined with Tylenol. I don't think it's
exactly.
the yeah.
Yeah. Yeah,
It's
exactly.
not
So
enough effect, because sometimes I think it is the big operation. It's not a big operation, but it makes the baby still got pain if without opioid. So sometimes in our country we use the ibuprofen and something like that. I don't know
Mhm.
in your about your department.
Yeah, I think so. Generally, we use Tylenol as first line. The surgeons will infiltrate local anesthetic at the port sites. And these are generally done laparoscopically here, so the incisions are very small. And so I think that is significantly less painful than if you were to do like an open pyloromyotomy. Um, Ibuprofen, I think I can't remember the age at which we start giving it here. I think it's around 6 months, but I'll have to look to be exactly sure. So I don't think we generally give ibuprofen to kids quite this young. Um, if the kid is having significant pain, they've already are receiving scheduled Tylenol, and they did get local infiltration at the surgical sites by the surgeons. There are options to do additional regional anesthetics. You could do transverse abdominis plane blocks, although the data doesn't really support it being any better than actually just the local infiltration by the surgeons. I think if you have a kid who is having a lot of pain, and you can consider using opiates with the knowledge that they need to be very, very closely monitored. If you were to do that, I would probably start with very, very low doses. Um, but I think in general, Tylenol and the local by the surgeons actually is adequate for these patients.
Okay. The other point. So on interesting thing from your presentation is the baby get fit in after 2 hours.
Correct. Yeah, our protocol here is that they
Oh,
remain nothing by mouth for 2 hours after the surgery, and then from 2 hours onward, they're able to resume feedings as normal. And he was able to do so without any sort of issue.
and because who will decide this prescription? Because normally maybe the surgeon they don't want to fit the patient early from my
Uh,
country from my country.
Gotcha. That's actually a decision here that's made by the surgeons when they resume feeding, and the 2 hours after the procedure is the protocol that we have in place that the surgeons have agreed upon. So they have a short period of rest after, and then they're able to resume feeding as normal. Um, I'm not sure. I actually don't know where that data or those guidelines come from. I just know that that's the protocol that we have in place, but I can look to see if there are guidelines. Um, for Friday. That would be helpful if you were having surgeons who are not wanting the patient to resume feeding early.
Yeah, because there's something it look like so new with us. Do you have any question more? Okay. So thank you, Dr. Scott, because I'm on duty now and I have severe case for my turn. So sorry because I have to leave now. But if from my resident, if they have any question, I think they will send to you for the next presentation. Thank you.